Hi, everyone. I am Eyal Azer. I am one of the brain radiation oncologists at Brigham and Women's Hospital and Dana-Farber Cancer Institute in Boston, Massachusetts. And today I'm going to be talking about a trial we have involving screening MRIs of the brain in patients with advanced breast cancer. So consensus guidelines recommend screening imaging of the brain for certain primary cancer sites, including non-small cell lung cancer, small cell lung cancer, melanoma, and some rare sarcomas. But most other cancers are not recommended to be screened when it comes to the brain, and that includes breast cancer. Historically, it was thought that the incidence of breast cancer spreading to the brain may be lower, but recent data has suggested that the incidence of brain metastases in some settings within breast cancer may be higher. Specifically, if patients have metastases to other distant sites, including the lung, liver, or bone, such patients may be at risk for having metastases in the brain. And this is seen in the population level data presented on this slide, as well as some clinical trial data which monitored for brain metastases and tabulated the incidence of brain metastases on this slide. Patients with inflammatory breast cancer may also be at higher risk for dissemination of tumor cells into the brain. What's also notable about management of brain metastases is that we typically manage them based on the number and size of metastases present. So when there are a fewer number of metastases or smaller metastases, we can use less aggressive forms of treatment, such as systemic therapy alone or targeted radiation. However, when the brain metastases are more numerous in either size or number, meaning bigger metastases or a larger number of metastases, we typically need to use more aggressive forms of treatment, such as whole brain radiation or surgical resection. So this slide shows institutional data looking at non-small cell lung cancer, NSCLC, versus breast cancer, where non-small cell lung cancer patients were largely screened and breast cancer patients were largely unscreened for the brain. And it looks at how patients presented with brain metastases. And what you can see is that patients with breast cancer typically had more brain metastases when they presented. They were more likely to have brain symptoms when they presented. And whole brain radiation was used more commonly in patients with breast cancer than in patients with lung cancer. And it's possible that the latency to detection of these metastases, which allowed them to grow in size and number, may have been responsible. So that led us to design a trial in which patients with advanced breast cancer who are at risk of developing brain metastases can be screened with MRIs of the brain to see if brain metastases are present or not. So there's two main groups of patients that are eligible for the study. The first group is on this slide. These are patients with metastases to other distant sites, such as lung, liver, or bone, or breast cancer that is returned in the breast or regional lymph nodes, but is no longer resectable. And those patients undergo a screening MRI of the brain at the time of enrollment. If brain metastases are seen, there's a multidisciplinary discussion regarding optimal management. If brain metastases are not seen, then a second screening MRI of the brain is done at the time of first cancer progression outside the brain. And if that scan is negative, no further MRIs of the brain are done for screening. There is a second cohort that is eligible for this study, and that's patients with inflammatory breast cancer who have localized disease, meaning we're treating the breast disease or disease in the breast and regional lymph nodes. And in those patients, they also have a screening MRI of the brain at enrollment, but if that one is negative, they'll undergo MRIs of the brain every 6 months for 2 years, at which point no further screening is recommended for the trial if all of the MRIs have been negative. So patients are eligible for this study if they fall into one of those two groups. Again, breast cancer with extracranial metastases or unresectable local recurrence, and those patients have to be managed with first through fourth line chemotherapy, or if they have hormone receptor positive HER2 negative subtype, any therapy first through fourth line after CDK4/6 therapy would count. Or the other group is patients with inflammatory breast cancer being managed with definitive intent. Patients are not eligible for the study if they cannot undergo a contrast-enhanced MRI, either due to a non-compatible metallic device, a bad contrast reaction to the gadolinium, the contrast used for the MRI, or significant kidney disease. In addition, patients cannot be pregnant or have a prior diagnosis of brain metastases. The primary endpoint for the metastatic and unresectable local recurrence subtypes or subgroups is symptomatic metastases at diagnosis relative to historical controls. So what we're trying to determine is if we can spare patients neurologic symptoms and the consequences of those neurologic symptoms via screening MRIs of the brain. And in the inflammatory breast cancer group, we're tabulating the cumulative incidence of brain metastases over time. There are some secondary endpoints, which include imaging type findings, clinical symptoms and treatment strategies that are utilized, and then assessments of quality of life and neurocognitive function. This slide shows both the targeted accrual based on the group that patients are in, as well as the subtype of breast cancer that they have. And one point to highlight is that patients of all subtypes, meaning HER2 positive, triple negative, or hormone receptor HER2 negative, hormone receptor positive, HER2 negative breast cancer are all eligible for this study, along with patients with inflammatory breast cancer that's localized regardless of subtype. We're always happy to talk about the study, answer questions about the study, and help further the study along. So if anyone has questions, this is the email to the study team, and we'd be more than happy to discuss further at any time. So thank you so much for inviting me to speak on this trial, and thank you to the audience for your attention. Thank you.